So again, congratulations to all the teams who presented this morning, and now we'll have our second grouping this afternoon. And as you can appreciate, as much as it's hard to go early and first, or one of the first group, it's really hard to go after lunch. And so we had great energy and enthusiasm this morning, so I'm hoping we can hang in there. The sugar should kick in about 1:23.
Excellent.
And that'll be good. But we will run through the next 5, and then remembering that we do have our interactive session at the end of the day to share some of your experiences around the quality standards. And as I mentioned, Michelle Rossi's here from HQO and very interested in hearing what did this look like on the ground, what does it feel like, and what advice do you have? Because as you know, there are many quality standards that have already been produced, many in the pipe and many planned. So your feedback is really important to us. So that'll be a great session to end off today. But more important, the first session after lunch, the Woodstock Mental Health Collaborative Project, Thames Valley Fit, and Woodstock General Hospital, Christy, Christine, Deborah, and Jillian.
Good afternoon. Thank you for being here after lunch. Give yourselves a shake. We're waking up. So,
I'm going to interrupt you. Christian, can you, there, thank you.
Oh, great. Thank you. So, I'm Chris Hagan. To my right, I have Deb Northmore, Jill Blair, and Christy Cook. We are very delighted to have had the project sponsorship of Carrie Selkirk from the Thames Valley Family Health Team and Michelle Worsfold from the Woodstock General Hospital. And we also would like to thank very much Shauna Cunningham for her terrific leadership in this regard. So what I would like to do is just give you an image. So here's a picture. It's early January, and I come back, it's after the holidays, and there's a 56-year-old male I've been working with for some significant anxiety around some situational stress. You know, how you been? He says, well, my neck's a bit sore. I said, oh, okay. Yada, yada, yada. He's been hospitalized for 9 days following a suicide attempt. This is not our presentation. No. No. This is yeah. Oh, okay. We're going to wing it. All right. That's the way to do it. We're going to add it. That's right. It was just a PDSA. We're really just going to move on here. So what we're doing next is we want to let you know that at the same time, there unfortunately, in Woodstock and Oxford County, there was quite a crisis of youth suicides. And we actually had a picture of a newspaper headline that talked about the call from the community to be able to have mental health providers collaborate on providing services for mental health issues, specifically around depression. So my situation with that gentleman, all I could think of was, how can I not know that this person just went through that? How can I not have that information? And we have it in the context of this particular crisis around youth suicides. So that's the type of environment or context in which all of our experiences as a team occurred. Yep. Okay.
All right, so with this being the backdrop in the Woodstock community, the mental health stakeholders were well aware of an urgent need to work together more collaboratively. And a key piece identified was a lack of communication between the stakeholders, clearly. So when the opportunity to engage in the Ideas Project presented itself, our team chose to focus on this quality standard number 12, transitions in care. So our aim statement addresses the discharge transition from patients at the Woodstock General Hospital to Thames Valley Family Health Team with the primary goal of improving PHQ-9 scores reflected pre-discharge and at the first follow-up visit in the Family Health Team, as well as the transfer of discharge information and the creation of a follow-up appointment within 1 week in the primary care.
So I was really grateful to hear all of your projects because a lot of our PDSAs ended up being around the communication pathway and making sure that we were doing it effectively, meaningfully, and we were providing relevant information. Woodstock General Hospital with the family health team decided to focus on our site as a good starting point for communication of discharge care plans. So what we actually did was we developed a tracking sheet for all family health team admissions, and then I went through the process of engaging those specific patients in a discussion about collaborative discharge planning and the benefits of follow-up within the 7-day standard of care. So that went well. Almost all of their patients consented to participate in the project. So what we did was we did an initial PHQ-9 score at admission, and then all of the discharge information, consultation note, appointments, medication list was discharged to each primary care physician on discharge along with the PHQ-9 score. It was very difficult because there's 15 physicians operating out of 2 sites, each with their own clinical person, so that's a lot of faxes going out to a lot of different places. So we had to involve a nurse navigator in order to ensure the physician was aware of discharge, aware of the follow-up appointment date, and they could follow through effectively.
I'm going to paint you another picture, and that is of, just imagine the best chart you've ever seen in your life. Never seen a better P chart. It was the process measure for the number of days to, from discharge of hospital to follow-up. And basically what I can tell you at this point is that it represented a stable process. There were no special cause variations and no trends. We can't even say it was promising. We just didn't have anything other than stabilization, so that's okay. So what we can tell you is that the average number of days from discharge to follow-up was 15.4, which was twice the prescribed time per standards of care, which made us ask why not within the 7 days. Let's do a PDSA. Let's track the reasons for that deviation. And then there were just a couple of other, we did see, they weren't exactly special cause variations, but there were 2 patients whose follow-up dates were over 25 days, so we had to be able to look at that as well.
So, using your imagination again. We did not have enough data, outcome data at this point, to assess changes in PHQ-9 scores. So that's ongoing. What we opted to do is focus on a second process measure, which was patient attendance at the first follow-up visit. So our data was subgrouped into October, November, and December, January to accommodate for some zeros in the numerator, and our mean attendance rate was 36.8%. Higher, we could see the chart going like this, the higher in October, November, dropped in January, December, January. Again, this is baseline data, so we don't have any previous information within our organization to compare.
So try advancing your slides now. I think you, yeah. We imagined so hard, I think it came true.
Okay, so there we are. Aha, there we are. Perfect. Yeah. So you can see this decline in the attendance rate. Obviously, this is something we want to look into. It's speculative. There were holidays in there. We know this is maybe a population that doesn't do all that well with follow-up appointments. And it also has us asking questions about the relevancy of those follow-up appointments. What's in there for the individual who's going to make that effort to get there? But we're going to talk a little bit more about that as we go.
So qualitatively, it was interesting because we were going to look at PHQ-9 scores, but we didn't even get there. What we got to was a standardized process. We got to standardized appointment scheduling with family physicians, and I had more conversations at the time of discharge with the physicians accepting patients into their care. And what I found was they were saying, Jill, I know you're going to schedule them within 7 days. Please don't do that, and this is why. They have an appointment, they have follow-up tests, they have other things that are going on. So if medically you set them up in 2 weeks or 3 weeks, or I'm going to reschedule the appointment anyway to a later date, then we can account for the medical changes, follow up on the mental health care needs at the same time, and we're going to have a more collaborative care plan, and we'll be aware of everything that's going on. So the meaningfulness to the physicians and to the patients was very important, because we didn't have a very good follow-through rate. Patients weren't showing up to their appointments. They were scheduled, they weren't following up, because they didn't have a goal and they didn't see the relevance in the follow-up. So the patients that we worked on to kind of figure out why you're going to the appointment, what's important, why primary care needs to be in the loop and be aware of your mental health discharge care plan, those were the patients who actually followed through, and we were able to track those PHQ-9 scores. We just didn't have enough of them.
Wrong one. They're not linked. Okay, so what we're learning still, or what we've learned relating to the transitions, how to provide meaningful information for the patient and the provider. So that communication pathway is really important. What information we are sharing, and what is the purpose of what we're sharing? Are we sharing something just because we have it, or is it actually meaningful and useful? The relevancy, so those who showed up had a goal or purpose for the follow-up appointment. So the 7-day follow-up doesn't mean anything if the patient doesn't see any meaning in it. Teamwork. Team members perceive the value of change differently, and that's reflected differently in the perceived workload stress or ease of adaptability. So the ability of a group to work effectively is how safe the team feels together. And, oh dear, I put them right beside each other. I couldn't figure out. So the next steps to progress improvement. So one, we would like to continue with the current PDSA, maintain the spreadsheet, continue the process, capture all the fit patients, not just those with MDD, but all of them. So as has been discussed, we ran out of time to really capture the data. And we would like to continue to identify if the discharge package is valuable. And then secondly, for the future, we would like to gain enough data points to evaluate.
Keep going. Keep going.
Thanks. To evaluate the PHQ-9 scores. We want to discern the risk of relapse or readmission. And also, we want to expand the process to include other community partners. Thank you.
Excellent. Thank you. You know, Ross mentioned that, being adaptive and being flexible, so thank you for demonstrating that for us. We really appreciate that. That was fantastic. Of course you did. Thank you. Thank you so much. Ross, go ahead.
So thank you for being adaptable. Thank you also for this round-robin presentation, which was very well done. One of the questions I have is about your understanding about why it's been so challenging to get the PHQ-9 scores. What is it about the way in which they're collected and transmitted that makes this, and what are you thinking you will do? Is it just a matter of getting the routines more standardized in terms of who's doing the assessment and how it's being shared? I need to understand that.
Yeah, and so a huge part of that is just the simple structure of the family physicians in town. So while we're a FIT, there's 2 FOs, and they, for the most part, operate independently. So that's the major factor, is just that we don't have that interaction to kind of get everyone on board. I mean, everyone's open to it, and they forget just because we don't, like I said, have that face-to-face and be able to remind them. And it's just our communication solely through email, so things get lost that way. So that's a huge part. Did you?
Yeah. And I think it was difficult for the physicians to follow through, because the initial PHQ-9 scores were all being sent, but the barrier was client follow-through. So the physicians can't assess if they're not showing up. So one of the barriers I had, there's one social worker doing the work in the inpatient unit, is having the time to have a real conversation with the patient about the value of showing up for their follow-up appointments. And that's really important because the people who their physicians engaged with them and I engaged with them, they showed up. So it's about having that meaningful dialogue about follow-up.
And that's a very important piece of learning right there, right?
Great, great presentation. Thinking on your feet to go through it. That was really good. I'm just curious. You shared the feedback that in some cases the feedback you received was that actually having a longer time than that 7 days was actually beneficial. It could be good, helpful. How are you planning to integrate that learning or further explore that? Because that's pretty big.
I'll take a stab at that. So that was, for us, that was just kind of one of our pieces that we had to let go. We were kind of stuck on that and felt like that was, I guess, a sign of failure, that we weren't reaching that, we weren't attaining that. So for us, I think we just took it as a lesson I don't necessarily know that there's a way to integrate it, but just that it's okay if it goes beyond that. But I should also state that a contributing factor to that is the fact that some of the physicians have hospital privileges and some do not. So those physicians that are in there admitting their patient and seeing them through their treatment are the ones actually that are saying, I don't need to see them within a week. I'm fine to see them later on. So that's a contributing factor as well. Anybody else think? Okay.
Yeah, because having the nurse navigators involved has also been really helpful. I'd like to have the opportunity to be able to have a consistent contact point that I could be like, hey, this patient is being discharged. This is what I'm thinking about scheduling follow-up. Do you guys have anything else that's going on that'll impact that follow-up date, right? Mm-hmm. To be able to touch base consistently with a person would be very nice as well.
Mm-hmm. That's such an important learning. I think we can get hung up sometimes in projects or things with a date. We have to meet, 7 days or whatever it is. And if it's more meaningful or more beneficial to not worry about that date so much, but what's the value in the, as you're saying, those conversations and that setup, that's a heck of a lot more important, I think, sometimes. So great presentation.
Excellent. Thank you. Thank you very much. Improving depression care at the Village Family Health Team, David, Anna, and Ranjana. Yes? I never know which way I'm looking. I think, okay, who haven't I seen up here yet? Oh, you've got the right clicker, so you're good. There's only one there now.
Okay. So hi, everybody. So this is us. You can see our faces up there. We're the team. And that's Diana, the fourth person. She's our executive sponsor. The other people involved with the project is we had 5 physicians out of the 11 at the family health team who were involved in testing the change ideas. And we had the front desk also involved in helping us. So in terms of getting the patient's story, it was really important that we did the initial process, that we did a current state analysis, because none of us really knew what it was like for a patient coming to the family health team and being diagnosed with depression for the first time. So we learned a lot from sitting down with everybody and kind of hearing how it works. And there was a really obvious problem area. So patients were coming in, they were identifying mood symptoms, the doctors were sort of assessing them, but everybody had a different way of assessing them for depression and screening for suicidality, and they were giving, recommendations for medication, adjunct therapy, psychotherapy, and then they were seeing them within some were 6 weeks, some were 30 days. It was very, very varied, and only if they had decided to start taking medication. So people were essentially falling through the cracks. So that was something we wanted to target right away. So what were the things that really helped us with implementing the change ideas and getting this project going was regular meetings. Communication was key. It was really, really hard to get everybody to communicate with each other. The doctors were busy. We were busy. Not everybody was on site all the time.
Speak closer to the microphone. They can't hear on the live cast. There we go. Thank you.
Not everybody. Sorry, I hate standing behind this thing. So not everybody was in the building at the same day, at the same time. So that took a little bit for us to get working. And once it did, it was amazing. There was also key pieces around educating the physicians on the importance of PHQ-9s and on the importance of more frequent follow-ups. And that went really well. All the physicians really bought into that. A few of the challenges is our EMR is very, very challenging. It's almost impossible to pull data from it, and in fact, we're changing EMRs. So all of our change ideas had to be something that didn't depend on the EMR, which was quite challenging. And also, we kind of wish that the physicians were more involved in the project. We wish they were coming to these educational sessions as well. So our overall aim was to provide better depression care at Village Family Health Team. We wanted to see more people improve faster. And our project aim is we were hoping by February 28th that 50% of the patients we recruited would have a remission in their symptoms, meaning a PHQ-9 score decreased by 50% and a score less than 10. So the actual changes that we implemented, if you look at the change ideas column, it sort of lists exactly what were the things that we did. I'll focus on the first two. The main thing that we did is we standardized PHQ-9s at assessment and at every follow-up, which was not happening before. There was no objective measure, and we've had 100% success rate with, by the way, so that's been really fantastic. And then the other thing we've implemented is the 2-week follow-ups. And as the other team was talking about, having people come back for a follow-up has been a challenge for us. But we really thought it was important in terms of treatment changes and medication changes. There's so much evidence in the literature that states that by the 2-week point, most medication will have some sort of effect. Physicians will know that there's something that they can do to change, whether it's working or not, and also that it's valuable to still see people, even if they aren't taking the medication, to follow up with them about their adjunct therapies. But people weren't coming. So there was a lot of problem solving we did around that. One of the things that's been the most effective is we standardized the appointment booking. So that's having some success. And then I'll talk a little bit more about some more things we're going to do to address that.
So as it has been already mentioned that our EMR is really challenging, especially when it comes to the data extraction. We had no choice but to collect the data for this project outside of EMR. So we collected all the data in a separate spreadsheet. We started recruiting the patients from mid-November, and our target was to recruit 20 patients for this project. And in 3 weeks of period, we were able to recruit 9 patients. And after that, for a month, there was no recruitment. From the physicians, there was no patient being reported that, yes, you can add this to the project. So we had a little intervention there. We had a meeting with the physicians where it was clarified that what kind of patients are eligible for this project. There was a miscommunication or misunderstanding that physicians thought that we are only looking for the newly diagnosed patients. So that was clarified, and after that, we were able to recruit 7 more patients. So by February 8th, we had 16 patients. Out of those 16 patients, by mid-Feb, we had 8 patients where we had at least 1 follow-up visit data available, right? So for those 8 patients mentioned on the x-axis, and the y-axis shows the percentage change from the baseline in their PHQ-9. And there was a drop of 44% in the PHQ-9 on average for those patients. Our aim for this project is to have 50% of the recruited patients to have 50% reduction in PHQ-9 and PHQ-9 score less than 10. And by the follow-up visit 2, for those recruited patients, we were able to achieve our aim.
So just really quickly, our clinical outcomes were that prescribing habits have changed and follow-up habits have changed as well. And essentially, our patients who are presenting with depression are just receiving much more attentive care. And in terms of efficiency, productivity, and effectiveness, patients really are recovering faster, and the doctors have reported a minimal impact on workload because their depression patients are getting better faster. So the next steps is we're going to be testing GreenSpace, which is a web-based, email-based service. We're thinking maybe if we email the PHQ-9s to patients and do virtual check-ins, maybe they'll be a lot more likely to actually get those PHQ-9s within the 2-week point. After that, we want to spread the intervention to all the doctors, not just the 5 test doctors. And we're going to be continuing to provide data at least annually to all of the doctors at the practice about how this project is doing. And then in general, we just found it so valuable to maintain a focus on quality and collaboration in all work environments. So that's that.
Excellent. Gee, a challenging EMR. Never heard that story before. That's right up there with the forms committee. Ross.
So you've clearly changed some of the ways in which you're treating these patients in their visits. Tell us a little bit about how the physicians came to that decision. Were they reviewing patient charts, or were they talking about their experiences? What was the mechanism that led to the changes in the medication regimes for these patients?
Yeah, so the doctors initially were all under the impression that you wouldn't see an effect with an antidepressant until 6 weeks, and that and they were titrating up to the therapeutic range very slowly. Right. So they all had a really conservative approach. And then what we did is we actually presented meta-analyses and a literature review to all of the doctors at a team meeting that actually showed otherwise, and that backed up the quality standard recommendation for 2-week follow-up.
Great.
Yeah.
Beautiful swim lane process map, first of all. I love that. That's great. Just wonder if you had any opportunity to get feedback from patients through the process, if they were feeling or noticing a difference.
Not yet.
Next steps.
Good answer. Comments or questions from the group? What are you curious about? Oh, right there, Joe.
I don't know if the mic's working, Tristan. You could start speaking.
Can you hear me? Oh, okay. I just want to share a bit of a PDSA that we had at our clinic, and it was around the EMR and getting PHQ-9s. And this was prior to us even starting this project. In fact, this was a number of years ago. Some of the staff had asked for we have PS Suite, and had asked for the Ocean tablet to be added. And there was just a little bit of, feedback saying, oh, that's expensive, whatever. And so we piloted it. And it was immediately successful in terms of getting the information while the patient's waiting in the waiting room. And so that was one thing that we really felt in our project made it very successful, because doing the PHQ-9s, they're sitting in the waiting room, they do it just downloaded right onto the chart, and we're able to look at that, and everyone's able to look at it real time. So if I was seeing the patient and then the counselor was, it's just right there. And we also could use it as a talk point too, because there is, we hypothesize that there's a difference between asking those questions on the PHQ-9 in person or also doing them electronically. So what we started doing was going through the PHQ-9, not just looking at the scores, but asking the questions, looking what was scored high in there, and then taking that and just sort of framing your assessment around that, and it was really successful.
Yeah, our next EMR will incorporate tablets. Yeah.
Thanks. Any other comments, questions? Excellent. Thank you, folks. Enhancing client-driven care for major depression, Tapo, Andromiola, Carla, and Natasha. Excellent.
Look at me, looking for Joe. Hey, Joe. So this is our team. We're from Wellfort. We're a community health center in Brampton. And today we have, on our team is Carla, who's one of the nurse practitioners at Wellfort, Tapo, who's the clinical counselor, Annie, who's also a nurse practitioner, and myself, who's a social worker. Thank you to Joe for all of your help. So our system aim, how do I do this? Yeah. Yeah, that's us. Our system aim essentially overall was that we were trying to create space and opportunities for clients at Wellfort who were diagnosed with major depression. And like other teams like the team that was just up, we're talking about clients who are not just newly diagnosed, but had been diagnosed previously. Creating space for them to utilize more services in the organization. So access to things like not just the nurse practitioners and the doctors, but also clinical counseling, social work. We have a dietitian, physiotherapy, all of those other pieces and community initiatives that we have going on at the center, in hopes that by increasing integrated care for these clients, that they would be more involved in their care, and we would see what our project aim was to enhance client-driven care, in hopes that by March 2nd, that would be today, 50% of female clients age 18 to 65 will see a reduction in their PHQ-9 score by 50%. You'll notice we did focus on women, and we can talk more about that at the end if you want, but we did focus solely on women 18 to 65. So the quality standards that we looked at in our project, the biggest one I think that we addressed was monitoring for treatment adherence and response. Some of the challenges that we saw with that were that we needed to be able to properly adhere to this health quality standard. We needed to do pre-booked appointments for that 2-week follow-up, and the subsequent follow-ups. We needed to be able to book the clients that had been diagnosed or been started on medications, all of these pieces, to come back within that 2-week period. And pre-booking wasn't something that we were always doing with clients. So that's a part that we're still working on, is trying to figure out how to best do pre-booked appointments, as well as make sure, which was a problem I'm seeing with lots of other people, that we're not having a lot of no-shows with those pre-booked appointments, that people aren't showing up for them. So we're still trying to work on how to best figure that out, whether it's with follow-up reminder phone calls, pieces like that. We also worked on treatment after initial diagnosis. Some of the issues that we saw with that were around, particularly with some of the populations we work with, our cost with medications. So if people aren't being able to access Ontario Drug Benefit or other insurance plans, cost for medications was a big barrier. At the beginning of our project, access to psychiatry was also a really big barrier. The wait time for psychiatry was a big barrier. We now have a psychiatrist in our office pretty regularly, every 2 weeks, which has decreased that and been really amazing. Shared decision making. We also looked at, and one of the challenges with that we noticed was people seeing the provider as the expert and feeling like you know best, and so tell me what to do. And really what we were looking to do was get people to be involved in their care and tell us, like, you're an expert as well in your care. What's going to work for you? What's best for you? How are we going to make this work? Our changes, as you can see, we were super ambitious. We had lots of changes that we wanted to implement, and we did implement a lot of changes. I think our team has talked about looking back and moving forward, the way that we can keep this sustainable and the way that we can do this best in the most meaningful way is to focus a lot more on one change or 2 changes, because we had a lot going on. So some of the changes we did is that we had more regular PHQ-9, like following that health quality standard, doing the PHQ-9 at regular follow-ups. We were able to do that with different providers and in different ways. So we did some in person, some over the telephone, but with different providers as well. One of the things that Annie and Carla did that's been really amazing is implementing a depression flow sheet where all of the providers can look at this sheet and have a really good understanding holistically of what's going on for this person. So depending on different providers that have seen them, they can all input into this flow sheet what's going on. Tapo and I started a psychosocial support group for people who had been diagnosed with depression. We did the pre-booking. We started the pre-booking, which we're still working on. There's other things up here, but some of them are things that we were already doing, but we're just sort of trying to keep them going.
So here is the quantitative impact of our change idea. As you can see from the graph, our results indicate a 9% reduction in the PHQ-9 scores for all clients when we compare the baseline to their follow-up visits. So for some clients, this meant 4th and 5th follow-up visit, while others it meant the 3rd or the 2nd follow-up visit. We had to ghost 2 clients, clients number 7 and client number 19, as they were not engaged in their treatment plans. So as we look back through the chart as to reasons why, some reasons we found were things like language barriers, lacking resources, and both of them did not attend groups. So were we able to prove our theory? Yes and no. In the short months that we've conducted this study, we did see a 9% reduction, as I discussed just now. However, we did not meet our target, which was the 50% reduction in PHQ-9 scores. We did see, however, a rate of increase in the rate of return when clients were pre-booked for their follow-up appointments, which we never did prior to this study. And we found that standardizing practice resulted in improved patient satisfaction overall, especially engagement with the entire mental health team. On the other hand, self-care strategies did not increase when we use our wellness passport, which we've created prior to this study. And clients reported becoming tired of answering the PHQ-9 scores in follow-up appointments. They felt this was redundant. We'll talk a bit more about that in a bit. Those who accessed other supports in the centers reported that services were beneficial to their overall well-being, whether this is social work, counseling, physio, etc. Clients and clinicians reported difficulty with accessing pre-booked appointments, as some providers cannot currently pre-book appointments by themselves. So we handed clients an appointment card, and they could go to the front desk and book themselves in. And reminder calls helped with follow-ups and consequently adherence to treatment plan. But as Natasha's discussed, just for the course of the study, she did reminder calls, but going forward, we'll have to figure out if this is sustainable. Definitely not through her role. So next slide. So in addition, we also conducted qualitative interviews with 3 random participants from our sample group. These interviews were conducted by a member who's not part of the ideas group, just to decrease bias. Overall, we found that clients that did attend groups found that this was helpful to them in coping with their mental health diagnosis, and they were pretty happy about the groups being held. So now I'll turn it back over to Natasha for conclusion.
Oh, no, that's still you, but I can say it. So clients, did you do this? Go ahead. No, okay. Clients who willingly, our enablers were the clients who willingly participated in the project. Our colleagues helped. I have 1 minute left, so I'm going to go to the next step. We can go back to that. Next step. So what we want to do is roll out that depression flow sheet to the rest of the team, the other providers in the center, because right now it's just the 4 of us. We want to make PHQ-9 forms available to people sort of as a self-assessment tool to see, like, how am I doing? The people that have already had a lot of education around what it's for, what it says, and have said that it's meaningful for them. Do some more psychosocial groups that are really specific. We're going to start with some mindfulness, CBT groups for clients that have a diagnosis. We're exploring the idea of, right now I'm from a different team, so I'm not part of the primary care team. Primary care team doesn't have a social worker, they have a clinical counselor, but our roles played really different. Our activity was very different with the clients, and so is that something that's useful for clients, whether that's a client support worker or someone else in that social work role for people? We now have access to a psychiatrist, which has made a really big difference, which is great. Yeah, that's it.
Thank you. Do you all remember back when you had your first meeting with your advisor and we told you that your projects were too big? And you all thought, boy, am I going to teach those folks something, right?
They're still too big.
Yeah, they're still too big. Yeah, excellent. Ross or Michael, yeah.
So thanks for your ambition. And I appreciate also the time you took to get feedback from your clients. Just wondering, in addition to their reactions to the experience they had, were there any ideas that they surfaced that were helpful to you in your thinking about how you could redesign care for the group as a whole?
Clients did start asking for more specific psychosocial groups, which is why we're doing the mindfulness CBT. A client actually came after a group and asked for that because she had heard about it from somewhere else. Clients also liked the idea of phone calls just to follow up and do a PHQ-9 with them. We are trying to make them available to clients. We've shown them how to find them on the internet and all of that as a self-assessment tool, but they did like the idea of a practitioner calling up and going through, even if they've done it themselves, and just checking up on them.
Good, yeah.
I got two quick questions. The first one, you mentioned a lot of change ideas, a lot of really interesting change ideas. Were there any that after you tried them, you just said, okay, we've got to abandon this right off? I know there were some you mentioned that you might have trouble sustaining, but were there any that was just absolutely had to abandon?
The wellness passport was one.
So initially, we have had something we call a wellness passport, which is similar to some of the change ideas other groups have implemented, but we've kind of had that for a few years. And so at the initial meeting with clients, we'd give it to them, encourage them to bring it to every appointment, because then everybody who sees them can check up on it and all of that. And most times clients forgot. Most times they just didn't see its usefulness. So the depression flow sheet kind of took the place of the wellness passport, and it was more for us rather than the clients, because practitioners, anybody working with the client can go into the depression flow sheet, see their goals, see their PHQ-9 scores, what groups they're attending, if they're taking their medication, and all of that. But for us to ask clients to take care of this passport and bring it and carry it and take care of it was a bit much.
Mm-hmm. Interesting, thank you. The other question I was going to ask is the obvious question. So how come women and not men as well? Had to ask.
Okay, so we have a lot of clients with major depression. I think somebody mentioned a little while ago about 50% of our clients at Bramley CHC have some kind of mental health issue. And what we've found is it's a lot more difficult to engage with men with depression. There's stigma, there's denial, and a lot of them work or don't have time to come in. So we thought, because we only had October to March to work with a group that we would probably have more success with. Going forward, like with the mindfulness CBT, which I'm actually recruiting clients for, I am trying to get as many men in as possible across all age groups.
Great.
I think it made our project more manageable, it felt like, right? To make it a smaller amount of people, a smaller group. And then also, once we had already made that decision, but when we started doing the group, we noticed, oh, maybe it's a really good thing that this is women, because a lot of the issues that were coming up, I'm not sure the women would have voiced as easily if it had been a mixed group.
And we also feel that things that we have implemented in the later on, we can also expand it out to men.
Great, thank you very much.
Other comments or questions from the group? I'm going to leave that men being difficult to manage statement right there. Right there. Comments or questions? I'm not going to go there. We have to be done by 2:30. I'm not going to go there. No, I said it.
Men are not difficult to manage. I said it. They just require More finesse.
Yeah.
First one.
The wordsmithing is great. Anybody want to make a comment or question now, or this has become dangerous territory, hasn't it? All right, thank you, folks. William Osler Health System, Mental Health and Addictions Program, Care Transfer for Clients with Depression, Tina, Navin, Marianne, and Martine.
So good afternoon, everyone. I just want to, first of all, introduce our team. Unfortunately, Dr. Kaker is not with us. He's out of the country right now. We have Tina Smith-Krantz here to my right, who's our research analyst. Martine Lopez is our inpatient social worker on the unit that we piloted our project on. I'm Marianne, and I'm the corporate educator for the program. We also want to thank Daryl Yates, our executive sponsor, as well as Dr. Kozaczynski, excuse me, for all their support throughout the process. I also want to thank Rosemary, who is our clerical associate on Gen B, for her support and her hard work in making sure that we were successful in our project. And I also want to thank Joe for his amazing support, guidance, and leadership. So we want to introduce you to Frank. He lives in Brampton. He has a diagnosis of MDD. He's been on our inpatient Gen B unit 3 times over the past 12 months. During his hospitalization, he did not receive appropriate community follow-up, which caused readmission to hospital. Barriers that Frank has encountered was he was required to make his own follow-up appointments. He had difficulty getting a timely appointment upon discharge. When he was at home, he felt better and unmotivated, so he didn't want to attend his follow-up appointment if he had managed to make one. There was transportation and financial issues, and there was lack of available resources or supports to bridge in between the discharge date and the follow-up appointment. Our overall system aim, we wanted to reduce in-hospital readmission rates and suicide rates. Our aim statement, of course, changed throughout the course of our program. Our initial aim statement was that by February of this year, 75% of our patients discharged from our Gen B, which is our mood and anxiety unit at Brampton Civic, with a diagnosis of MDD, will attend a follow-up appointment with a healthcare provider within 7 days. Due to some privacy issues and concerns, we had to change our aim statement. So the new aim statement we were working with was by February 28th of this year, 75% of our patients discharged from the Gen B unit at Brampton Civic with major depression will be offered a scheduled follow-up appointment with a healthcare provider within 7 days.
So in terms of the changes that we tested, we increased the use of the Ontario Telemedicine Network to make appointments for patients. Many of our patients are from out of area and are in rural areas, and so this was actually pretty helpful and convenient for many patients. We actually also tested earlier discharge planning process. So previously we would kind of wait till closer to the discharge date to begin that process. Now we are starting discharge planning from the day of admission. We also had the luxury of having some psychiatry protected time through Dr. Kaker, who was able to provide the 7-day follow-up by protecting some time out of his schedule on a weekly basis. Another change of a test of change was improved documentation of patients' community connections. So previously, we weren't aware of who is this person connected to? Do they have an outpatient psychiatrist? Do they have a case manager? Who are they connected to? And so now, as a part of the admission process, we are identifying that earlier on in the admission so that we can then connect with those individuals to not only discharge plan collaboratively, but also earlier on within the admission. And then the last one was an improved communication between inpatient staff and our outpatient programs. So we do have quite a few outpatient programs who are able to provide that 7-day follow-up, but there wasn't enough communication going on between the two sort of programs. In terms of, next slide. changes. We are working to prove our theory that offering patients a timely follow-up will reduce readmission rates. We are working hard to ensure that patients are leaving with a timely follow-up appointment. It is an ongoing process. What we have learned is that involving staff in problem and solution identification, it's resulted in a very positive buy-in. Small changes put in place means that staff were able to adapt quicker and follow through with the new processes. Diagnosis was something that was not put on our census, and so identifying who in our inpatient, in terms of the patients that are inpatient, who has MDD as the admitting diagnosis. We also have a whiteboard in the back of our nursing station, which also identifies who are those MDD patients. Early discharge planning, which I mentioned before, scheduling psychiatry appointments as well. How have we adapted those changes? It is an ongoing process, and we continue to identify areas of improvement and put potential solutions in place. If an idea doesn't work, we are adapting to that. Enablers. So, our staff have been really enthusiastic and supportive of this project. They're open to new ideas, and the GEMB team believes of the importance of this project. Some of the challenges that we sort of encountered were changes in management. We've had quite a few managers over the last few months. We had a new resource nurse, so that was a lot of change in terms of staffing. We mentioned earlier about the privacy office having concerns about us contacting patients after they're discharged. And then there was also some difficulties with actually starting some of the PDSAs. And then as well, staff comfort level with those changes, though they were quite small.
So for those of you who your cupcakes are starting to act in and you're getting that sugar down, the take-home message from this slide is just basically that our wait times, like after we implemented our 7-day follow-up goal, our wait times for patient scheduled follow-up was lower, was shorter. But for those of you who like data like me, along the x-axis is the discharge date for each individual patient. Along the y-axis is the number of days. And you can see in the left-hand part of the slide, there's a lot of variation, a lot of up and down, large range. And then after our early discharge planning PDSA and our other PDSAs began, you can see on the slide there towards the middle, the variation is reduced, and we have a lot shorter wait times. Before, the average wait time was around 17, and then after our PDSA started, it's down to about 10. So nice results to see. Bringing it back to Frank in terms of some of the barriers, and then bringing it to some of the solutions, where before patients had to make their own follow-up appointments and often have difficulty making appointments. Frank was grateful that he had that follow-up appointment within the first week of hospitalization. Often within the first couple of days, he received the appointment. Patients felt better when they're home or unmotivated to make the follow-up appointment, so it's not made. That was a barrier before. And so now that Frank is getting that support, he has that follow-up appointment before he leaves the hospital, so he's able to receive that health teaching before he leaves the hospital to realize, okay, this is something really important, and that helps with the motivation we're thinking about in terms of maintaining wellness. Long wait times, like Marianne was saying, or Martine was saying, we're lucky that we have that protected time with psychiatry. Long wait times, of course, is going to be and continue to be a concern, but we're working with also our inpatient staff is working with outpatient services so that we have that communication that was there in place before, but it has been augmented now so that our inpatient staff talks with the outpatient staff to say, okay, this person's going to be discharged. What's that transition going to look like? How can we make that easier for the patient? In terms of distance, so some patients would have distance issues, financial difficulties for paying for parking even, transportation with the Brampton Transit. And so we have OTN for those patients as an option so that they don't have to go all that distance. Finally, lack of available resources and supports. So staff ensured that Frank's community supports were identified upon admission, and we collaborated
to promote a holistic discharge plan. Next steps, we really recognize the importance of staff and patient feedback, so we really want to continue with that to find out from their perspectives what's working, what's not, what can we build on, what can we change. Work towards sustainability within the current program. So right now our focus is MDD patients. So can we work that in, build that in so that we're including all the other diagnoses within our program. Staff and senior leadership education support. We're lucky we have great support ongoing. We'd like to see that continue. Work towards expanding corporately. We have diagnosis-specific units. So right now, as I mentioned, within Gen B, we have the MDD focus, and we hope to expand that. We have a Gen C unit that focuses on psychosis. We have a geriatric unit. So we'd like to see this initiative expand to those programs. In terms of other change ideas, we want to develop and establish further partnerships with other community agencies because we recognize as we move forward, we're going to need that community support to keep the 7-day follow-up going. I already mentioned about Gen B expanding to all the diagnosis and other units. And there was one other thing that you wanted to...
We're just also looking at creating a hierarchy in terms of if we're not able to get a follow-up appointment with a psychiatrist, who the next person should be. So a hierarchy of multiple options. Stop, thank you.
Nice timing, thank you. From the panel?
So great presentation, lots of interesting change ideas. I love this idea about, and we saw this in the Grand River example earlier, about booking appointments for patients, not assuming the patient's going to make the appointment, because we know motivation is a big issue, which you clearly described. So I think the question I would have, is that something you can hardwire into the way in which you're going to deal with these patients in the future, right? So if somebody on the team now is doing that booking, is there some way to put that into the existing process so that it's there, it's established as a way of dealing with these patients to make sure they don't fall through the cracks?
So yes, our clerical associate, who we kind of gave a shout out to, has been really instrumental in making sure that happens. Yeah. And because she only works days, but we do have an evening clerk, as well as sometimes we have casual clerks when she's off. So she's actually been training her other co-clerical associates to actually continue with this process. So it is become standardized.
That's great.
We were making follow-up appointments, but we just weren't doing it consistently.
Yeah.
So, I mean, the odd physician would say, oh, can you make a follow-up appointment for the patient before they're discharged? So we were making the odd one, but we're now doing it more consistently and in a timely fashion.
Yeah. I have another question, which is, you said earlier that some of your patients come from a distance,
yes.
So they're returning home. Do they have to come back to the hospital, or are they having a follow-up appointment in their own community?
So it depends. So sometimes they might already have a community psychiatrist that's within their locality, but many times they don't. So many of our patients actually come from Dufferin, and I heard Grand River talking about the limited resources for our CMHA within the Dufferin region.
Right.
So unfortunately, because of their limited supports, we at Osler are having to pick up the slack for that and are offering follow-up appointments to patients that are not necessarily within Peel region. And so we are offering them the option of them going to their local family health care team and having the OTN appointment there. Or some of them actually, interestingly enough, enjoy the drive down and make it a day, and it's a whole trip, and I'm going to go shopping at the mall. And so some of them prefer to come down and actually meet with their psychiatrist face-to-face, but at least they have that option now.
I think it's great that you're offering options, because instead of one size fits all, we can do things that make it easier for the patient to show up at the appointment.
I'll just echo Ross's comment too, and I was encouraged when I saw that you were looking at OTN and using that. I think that's such an important resource. It'll be interesting to see how well that gets utilized or how much that gets utilized, because that's pretty progressive. My question was with regards to the change in management. There's nothing that can throw off a project more than going through executive sponsors or having executive sponsor leave, because it's such an important piece. Any just really quick advice or ways that you've kind of navigated that to keep things on course?
Well, it was the executive sponsor remained the same. It was the manager along with the Gen B unit that changed.
Oh, okay.
So
We scheduled meetings with every manager, didn't matter who it was, so that they were well informed of what we were doing. And then there was a little bit of a bridge between one manager and another so that they could onboard the other manager to be aware of what the project was. The current manager has been fabulous and wholeheartedly supporting us in this, so we're very appreciative.
Great.
Excellent. Any other comments or questions from the group?
I'm curious what the
Thanks,
issue
Marie.
with the privacy officer is.
Yeah.
It's private, they can't tell you.
Well, we don't want to really belabor the point, but there was issues about being able to contact people after they've been discharged, and so because they're no longer our patients, because they've been discharged from the facility. So we are still trying to work around and do things like that to find a workaround so that how we can be able to contact them when they're no longer our patients.
And it's not only contacting the patient, it's also contacting the healthcare provider that they're following up with, because we're trying to find out, did they actually attend the appointment?
Yeah.
And so contacting, whether it be the family physician or the caseworker or their addictions counselor, whoever that may be, it's been suggested by our privacy office that we create some type of consent form. So we are looking at that, but we also need to ensure that there's an opt-out option as well for patients who don't actually want to be contacted upon discharge. So they are making suggestions as to how we can get around it, but there's been a lot of different interpretations of this particular law.
And once the patient is discharged, we're contacting them. We should be documenting. They're saying that we should be documenting somewhere.
Yeah.
We can't go into a discharge chart to document that we've contacted the patient. So that's. There's a few things, but we're trying to work through it. Yeah.
And one last comment, yeah.
No, this is sort of to carry on with that. Our hospital has had for quite a long time a post-discharge phone call program across all the different
That's
departments.
different, though. We do that as well from our.
But that has meant we haven't had any privacy issues because we have a form that we document on, and patients give us the phone number before they leave, which is implied consent.
It's a big topic, right?
Yeah.
It's a big topic. Yeah. Excellent. Thank you so much. Speaking of consent, we didn't plant that question, but speaking of consent, I was remiss in reminding you that the form that says we can take your picture, which we did all day, so thank you, is on your table. If you could sign it, just as we transition to our last presentation, if you could sign it, and we'll collect them off the table at the end of the day. But you can, it doesn't ask for a time, just a day, so you don't have to put 8 a.m. this morning. So, I think this group deserves a round of applause even as they come up, because they waited all day to do this. So come on up, and then I'll introduce you. So this is Care for Mental Health at UHN. Shane, Yami, Monica, Yulia, Tamara, and Judith.
I guess the trade-off with being the home team, we're based here at Toronto Western, is that we go last. So I think we accept that fact. So good afternoon. My name is Shane McInerney. I'm a psychiatrist here in Toronto Western Hospital, and my special interest actually is in mood disorders. So in combination with that and my interest in QI, I was asked by the executive sponsors, who are Jan Lagstrom and James Gambaris, down here, to become involved with this great community mental health team. For this IDEAS project. So I'll introduce the team. They are Monica Scalco and Judith Cadet from the Portuguese Mental Health Service. We have Yami from the AIM Mental Health Service, and Tamara and Yulia from the what we call the English Community Mental Health team. So we say 3 distinct programs, and we'll actually be presenting the results from each of the programs. So just to bear that in mind. So in terms of our AIM statement, we said that by March 1st, which I think is yesterday, that 90% of depressed patients with a PHQ-9 score of greater than 20, so this kind of more severe level of severity, at the time of their assessment would be offered an intervention, and this could be either evidence-based psychotherapy or indeed a medication option within 1 week of their assessment, and this is based on the Quality Standard number 4 guideline. So this looking at this timeliness to treatment. So we just picked one of the patient stories from our programs, and this is from the AIM program, the Asian Mental Health Program. So Miss T was a 56-year-old, or is a 56-year-old woman. She was born in Cambodia and came to Canada in the late 1970s. She had a history of war trauma. She had 2 children, but raised them alone and was on social assistance. She was referred to the AIM program by her family doctor in November 2017 for assessment of depression. She also had associated suicide thoughts and some chronic pain. A Chinese-speaking psychiatrist was indicated because of the language barrier that was present at the time. She was contacted on February 2nd, and then she was seen by just about 2 weeks later by the AIM clinician, who was Yami, for a full biopsychosocial assessment. Prior to the AIM involvement, there was ongoing treatment by the family doctor, and indeed an antidepressant was prescribed before her assessment occurred. So from the provider's assessment, her PHQ-9 at intake was 21, so in this severe category. A provisional diagnosis of depression and chronic pain was assessed. She was given a provisional appointment with the psychiatrist, which was scheduled a little bit further out, maybe you would expect later in March, but I'll come on to this in a moment. But the clinician, Yami, was providing ongoing care, psychotherapy care in the interim, and indeed the lady was offered the mental health promotion group, which is due to resume next week. She was found to be taking her medication and indeed benefiting from it, and there was no imminent urgency in terms of her evaluation. From her own perspective, she was pleased and grateful to be receiving support, particularly in her own language and in a safe, non-judgmental environment, and also to participate in a supportive group that would be available to her. She was actually offered an earlier appointment with the Mandarin-speaking psychiatrist, but she chose the later option of the Cantonese-speaking psychiatrist. So I think it was the Woodstock team that presented earlier, where that patient preference, giving them the option that the 7-day limit isn't, while it's a gold standard in some ways, that we need to have some flexibility around that. So I'll hand over to Judy.
Thank you. Hello, everyone. So I'll be talking about our change ideas for each of these clinics. As you can see, they're quite unique because we have different groups and that speak different languages, have different immigration experiences and different needs, even in terms of their cultural, their culturally and their perception about stigma. So in terms of the programs, we had different interventions, and they're all informed by our diagnostic tool. We use the fishbone primarily to have some sense of what the causes are. And the Portuguese team initiated their intervention in January this year, so it's really a small amount of data that we have at this point. And because we realized that the psychiatrist being away was really the main difficulty to getting these folks being seen within that 7-day period. So we, as of January, started to save and reserve that time upon the return and make sure that these folks that were seen by the clinician the week prior, for instance, will now be returning or be given an option to return and see the psychiatrist to have their treatment initiated. Or, in case this is not the option, we'd then proceed to offering a possibility of seeing the clinician. So each team had their own interventions. I'll just be very brief now. We had the English team also trying to book appointments at the time of intake, and they were booked simultaneously for the clinician and the psychiatrist. And the AIM team had 2 interventions. One was very timely, the timely return from a newly hired Mandarin-speaking psychiatrist that really started to seeing a lot of the clients, even with the help of the clinicians interpreting if they didn't speak Mandarin. Okay, so we'll proceed. So were we able to prove our theory? Yes, we know that psychiatrist availability is an issue, and it does impact on timely access. We also have a possibility to offer a lot of other treatment options, and we're fortunate to have a lot of different programs that have different group treatments and options that are very tailored to the needs of our clients. In terms of what we've learned so far, I think PHQ-9 is a great tool, and we assist us with prioritizing access to our clients. It helped us as a whole group on our whole floor, all programs across have this standardized screening tool that was not there before. So this is a great change, and I think we all adopted it and will continue to use it. And we are now have staff that have great awareness into what these guidelines are all about and why we need to persist and continue to implement all these changes. Just quickly go to the Portuguese data. So you can see that there's a 21 wait time for this August 24th date, and this was prior to any intervention. And all these dates coincide with the psychiatrist vacation or absence. You'll see one in December 5th. We had our ideas training that day, so she wasn't there to see her clients. So. So that's it. And so we have just a few recent numbers that we collected. And this SPC chart shows us what our 56 clients were like in terms of the progress. And we tend to book same-day appointments with the clinician and psychiatrist. And I think we're going well with the mean of 1.6 at this point also for this group as the balance measure. And English, please.
So this is the community mental health team, and you can see we implemented our PDSA, but we actually didn't have any data for the severely depressed. And I think, a few things count from that. We didn't have a large period of time. There was also, with the holidays, that impacted in terms of when the clinician was seeing them, when the psychiatrist was going to be available, or kind of along the process. And the other thing we learned is, for those patients who have severe depression, when we were looking at the data, that was under 10%. So with this short amount of time, we just didn't have a lot of data. So we don't have that for our severely depressed patients. And we're going to continue to collect data, so we'll see the results and see what that looks like. This is for those who scored mild to moderate, and so you could see that we have more patients in this category. And when you look at where our PDSA begins, we can see there is more of a stable trend, so we'll follow that to see if it stays continuous and have a sense of what that looks like. And just to comment another piece about those over 20, we do have also, we have pre-screening. So for those that are really concerned about, we can also refer them to our urgent care. So that also would account for maybe the lower clients showing up in our program with scores over 20.
As you recall, that the Asian team has 2 PDSA, so you probably never heard of a PDSA dropping from the sky, but that's certainly, there you go, so the first PDSA, would be, having a newly high Mandarin-speaking psychiatrist joining the team at the end of August. So all of a sudden you see that 0 days waiting, because just having an extra pair of hands and an extra member on the team, that it really bring, our wait time significantly down. So you see 2 ghost points on there, and we decided to include it, because we also offer group treatment. Initially, we only have 1 psychiatrist, therefore, we've been kind of trying to be innovative. So the patients, the 2 patients were offered the group. They did try, and however, they decided to drop out, and we also respect, their determination. Okay. Okay, and so then, this would be for the mildly, depressed patients. And as you see, there's a trend dropping down as well.
Take us to your next steps. There we go. Oh. Okay. One more.
I'll just highlight some of the enablers. So I think we use the PHQ-9, and everyone spoke before about this. It's been very useful to us. And the staff now has more of a tool that gives them a sense of how they can approach a patient, and really recommend that we need to prioritize your access to treatment now. And the patients also have some more sense of empowerment. There was a learning curve in terms of using it, but I think we're very good and are on track. And I think in terms of outcomes so far, we're very happy with what we achieved. We got staff together. We had a lunch and learn on the quality standards. We conducted fishbone exercises. All of us went to the different teams. So we had a chance to appreciate how they all participated in this process. And we're updating the QI committee at UHN, the Center for Mental Health, and we'll be very soon engaging with the steering committee and presenting as well, which she requested us to our executive and continue on from here. Thank you.
Excellent, thank you. So the panel has saved up their hardest questions for the end. So who wants to ask the hard question first? Ross, excellent.
So let me start with some congratulations, because you did several things here which I think are very useful to point out. One is you stratified your data, both in terms of the severity of the patients and also in terms of the teams, which had different resources and different client groups. So I think that's very important, and that makes it more real for the clinicians in each one of those groups, because they know that they're really dealing with their experience and not the combined experience. So I think that's really important. The second piece that I really liked about this was that you saw the team as offering a system of care. So the psychiatrist is in many ways the scarcest resource, and if you can't get access to a psychiatrist, you're building in interim steps to ensure that these patients are not falling through the cracks. On one level that seems really obvious, on another level it doesn't always happen, so I'd like to call that out because I think that's really important. The question I have for you now, and I really admire the way in which you've implemented the PHQ-9 across the system. What are your strategies now when you're going to get enough data to look at trends over time? What are you thinking about? How are you going to engage the clinicians in the program to use that data to really identify other ways in which you may want to influence the current practice?
So if I can answer to that, I think one point that I'd just like to tell everybody, like how big this was. We are a huge outpatient clinic. We have more than 80 professionals in the floor with different language-specific outpatient clinics and the English clinic as well. So only to have everybody working on the same goal was really interesting and very challenging. Of course, to change things is hard even on a personal level. Imagine if it involves 80 people. And going forward, I think that if we could keep that going, like identify goals that most of the groups can share and keep meeting from time to time and share one thing that we are now thinking, I think most of us, is waiting times. Yeah. How to approach, and I think we have support from our sponsors like Jen and Jim. So that's the goal right now, to keep the climate and keep working on quality improvement.
Yeah. Good, thanks.
I appreciate how you allowed each team to develop their own change ideas and PDSA them uniquely to the team. I thought that was pretty neat. Do you anticipate there being the opportunity for some cross-pollination between the learnings of those different teams and what was successful and not?
Yes, we had meetings like this. We went from group to group, and everybody had a chance to know what is going on the other group, so we can share ideas and kind of think, oh, maybe we can use that idea, or that doesn't work for us, but interesting. I think that enriches the process.
Okay, thank you.
Sure, yeah. And so I think one thing we did to help each other and support each other is, although our PDSAs were different, we're all using the same tracking sheet in terms of our data. So what's really cool about this is we now have, what are people being referred for, and we have our final diagnosis. So that gives us some really rich information in terms of even just program planning going forward. What does that look like?
Excellent.
We need to thank you, Joe, for all your support. You were really very helpful, like with a lot of energy, and we really thank you for being so present, like smart and wise at the same time, guiding us.
Thank you.
I have to cut you off because we have to live with him. So, yeah. Thank you, folks. And give this team a round of applause. Give everyone a round of applause. Great presentations.
Do you want to go up and
So as this team gets their photo, there we go. And thank you to everybody for your presentations today, but certainly for your engagement all the way through the day as well. And so this morning when Ross started us off, he talked about this cohort being somewhat of a, well not somewhat, being a PDSA. That this is the first time that we've been able to do a cohort focused on one of the quality standards, and that as a PDSA we are collecting data about how that worked. And so one of the privileges we have today is we have Michelle Rossi with us. Michelle was the former Director of Policy and Strategy for the Ministry of Health and Long-Term Care, but she saw the light and came to be the Director of Policy and Strategy at HQO. And so she has a very significant responsibility for the quality standards, particularly this one that you've been working on. And so really curious to get your feedback and to hear from the ground, how did this work for you? So I invite Michelle to come up, and we're really interested in facilitating a discussion with you about this.
Okay, thanks everyone. So I'm really pleased to be here because, as Alice mentioned, this was the first time we've done a cohort like this, and the Quality Standards Program is a pretty new one at Health Quality Ontario, so we are deeply interested in what your experience was in trying to implement this quality standard in a breadth of clinical settings across the province and to a wide variety of patient populations. So as mentioned, I'm the Director of Policy and Strategy at HQO, and my role in the Quality Standards Program there is largely connected to the governance of the program. So as part of HQO's governance structure, our board now has a committee. So every part of the Quality Standards Program is sort of run through this committee of the board that meets monthly, and they really kick the tires on all of the products and sort of interrogate the internal teams at HQO that are putting them together. And then they recommend to our board that those products be approved to go out into the world. So my original task was to get this committee set up under a solid terms of reference, get them effectively up and running, and they've been doing that since September, and now I kind of facilitate bringing all the different pieces across HQO through this committee so that they can get through the board. And then we have other relationships that play into the program, including with the government, of course, who is the funder of HQO and therefore the funder of the Quality Standards Program, and other partners like the LINs that are really instrumental in helping support the dissemination and the adoption of the quality standards. So as part of my role, I have a pretty good line of sight into almost all of the aspects of the program at HQO, but what I've really been wanting to learn more about is the experience of people trying to bring the standards to life in their organizations. And we've seen some examples of this through Quorum, and we have like quite a bit of champions who have been involved with the program who go out into the world and come back and tell us how that is, and we've seen some examples of how it's come to life, but I don't think we've ever had this concentration of experts who have all been trying to do this at once. So I personally couldn't resist the opportunity to come and take advantage of a little bit of time to get some of your insights. So, now we've got 8 quality standards posted and sort of disseminated out there into the world. We've got 6 finished. They're in the can and ready to go out, and they're going to be rolling out over the next couple of months. And then, of course, we have a number that are under development. So at HQO, we thought, really now is the time. We do like to sort of PDSA ourselves and continuously approve ourselves. We don't want to sort of wear that cow path and then turn it into a superhighway before we check ourselves. So we know that at the core, we need these quality standards in the province, because if we want to have excellent care for all, we need to know what good quality care looks like, right? So that's sort of our rationale for wanting to have the standards, and we need to know where there's unwarranted clinical variation, and when it's appropriate, we have to figure out ways to support improvement at a provincial level. But how the standards are being used to support improvement is probably one of the most important and frequent questions that we're asked from everybody from, our board to the Minister of Health himself, asks us that when we bring a new one. How are they actually being used to support improvement. So we need to keep that top of mind as we evolve the program. So it's the key for us to figuring out where to focus our energy and resources. I have a few questions that we had hoped that we could just tackle in the bit of time we have and have a bit of an open dialogue, and I hope that within like the confines of this room that you'll be frank and give us some really honest feedback and advice on what the experience of being a recipient of one of these quality standards was and trying to figure out how to implement parts of it to improve. Because what we really want to know is what those on-the-ground challenges were. So we can take this into account as we evolve our own program in terms of our processes and the products that we produce and what we do at HQO to make up the quality standards package. So I don't know if you have, I don't know who has the slides. If they're, oh, there we go.
You do.
There we go. I do. Sorry, I do. It's here. So, right. So I guess first we wondered if you could sort of think back to when you first signed up for this. And, how did your team or your organization decide what even to work on? Like when you got the quality standard, was it easy to sort of instantly identify where you needed to focus, or was it hard? Like, did you have information available to you, or did you have to take a stab at it and hope that it kind of turned out over time? I don't know if anyone has any reflections of whether they instantly sort of intuitively knew what to do, or whether it was a sort of shot in the dark for you. Like, how much of a leap of faith did you have to take when you took on the work, or was it the moment you were waiting for? Yeah.
So I think we've kind of all said throughout these projects, both the last set of presentations and today, that it was quite a challenge because we started out with thinking about so many things that we might want to tackle, and then just having to narrow down to one small thing. So no, it wasn't easy at all.
Yeah.
How many in the room listed all the quality standards on your application? Statements on your application. That's a couple of teams, yeah. And how many of you listed like more than 5? Yeah. Okay. And how about from somebody who just listed 1? How did you get to 1? I mean, that's what Michelle's really interested in hearing. How did you decide 1 if you just listed 1 or 2?
Well, I think in our presentation, we talked a lot about the context in our community around the need and the public request for mental health providers in various organizations in that area to be able to collaborate. And so for us, it was a pretty straight. We only listed a couple because it was a clear leader for us.
Go ahead. Yeah.
I think it was around, that was the only one we could really control. We had no control over a lot of the standards, so this was one we could deal with.
Yeah.
So in terms of William Osler, I think the decision was made for us to look at the 7-day follow-up standard because we had some health quality internal reviews as a result of completed suicides of patients, and there were recommendations that came out of that we need to ensure that patients were followed up in a timely manner to reduce the risk of suicide.
Anyone else? It's the end of the day. There's no batteries left.
Okay. With our project, we chose the adjunct therapies because self-management was something that our clinic in itself would really promoted, and that's one of our philosophies of care. So we knew it would be a good fit, and we'd probably have a lot of buy-in from the staff as well and from the patients.
Thank you.
I think that's part of the complexity of the quality standards is that the statements, there are a lot packed into those statements, and there are almost different audiences and different stakeholders for each of the statements. It's not like a one-size-fits-all, or you can hand a whole standard to one team that can, like we hear a lot of people say kind of cavalierly, like, implement the quality standard, but I think that's a kind of a simplistic way of looking at it, and I think your experiences demonstrate that there's a lot more involved in taking on an entire quality standard than kind of rolling it up into one single initiative. The second thing we were wondering about is, in the quality standard, we provide indicators along with each statement. And I was wondering to what extent, like obviously you all had a lot of data, you did a lot of local data collection to support your PDSAs and your projects. But did you find the indicators that were bundled with the standard? Like, did you use them or rely on them, or were they a starting point, or did you have to do a lot of customization based on your own circumstance? We do spend kind of a lot of time and energy like working through those indicators at HQO, and we haven't really had a chance to ask people to what extent they use them, or if that's kind of their go-to resource.
For our particular project, transition in care, I found the indicators very helpful, and we relied on them in explaining the why of what we had in our transition plan. So even in that, we had like asterisks in the plan that said HQO standards, the indicator is this, right? So I would, the one piece that I would recommend in those indicators is to have, if it's possible, have more resources available to be able to educate others.
Anyone else have any reflections on the data piece? No? Oh, yeah.
I think we would agree with and we'd aspire to those measures, but in the scope of this project and the time we had to back off and look at some sort of process indicators we could achieve in the time we had, in hopes that they were going to lead to those kinds of indicators. So we like them, but some of them would take some time and take some bigger change to actually impact.
Move them. Yeah, I think that's where capturing the experience of all of these teams, hopefully through the quorum and some of our other like communities of practice and that type of thing, so that your experience and where you all landed on what you had to do to advance your own projects, other teams can learn from that, and we can maybe offer a more comprehensive picture of what organizations might want to do if they want to tackle similar challenges in their own organization. And I guess lastly, just generally, what other advice do you have for HQO for how we can support organizations to adopt the quality standards? And this can be anything from supporting, kind of communicating them to get executive buy-in, to practical resources that we're offering, to how we offer those resources or how we make them easy for you to find. We're really looking for any feedback about what we could do to support people like yourselves across the province who might be, looking to dip their toe in the water and saying maybe we could implement some of this stuff too. But how do we make it as easy as possible?
I would love to see some links to the evidence that supports why certain standards statements exist, because I had to present some of the literature to the doctors, and I thought, well, wouldn't that be great if the literature was in the standards? So that's it.
Maybe in a way that makes it easy for you to incorporate it into such a presentation.
Yeah.
Yeah.
For those organizations that are required to do a QIP each year, Quality Improvement Plan, is to align the quality standards with the QIPs. So I know, for example, with us in primary care, we have a whole set of indicators that we're supposed to focus on for the year, but then we also have the standards and they're not the same.
I think from our team's perspective, it was very useful when we were going to, particularly when there's a very broad range of allied health professionals, doctors within different programs, to be able to say these are health quality standards. They've been approved and very much supported by the leadership team within the hospital, and we've been encouraged to undertake one of these quality standards. It kind of gave us a head start really in terms of a buy-in from the other professionals within the organisation to say these are quality standards. They're provincially led and driven by expert kind of collaboration and agreement. So we found them very useful, I have to say, and both the statements, and I know you mentioned about whether it was helpful or not, that they were very broad statements, but we found it very helpful because we had both, let's say, people who were interested in medication, such as myself, and then more expertise in terms of psychotherapy, and with the statement saying it could be either psychotherapy or medication option, allowed that breadth of options in our program.
So I think one of the strengths of doing it in this kind of venue or this mechanism is that we had coaches. We had coaches to help us with the change management. So I think if there's some way to have points of contact, and I know that there's HQO representatives in all the LHINs, but to really have that kind of ability to coach organizations through that change management, because there are points where you just want to completely abandon it because you're like, this is just not going to work. And you needed that kind of person to check in with to say, no, you can do this. Here's some diagnostic tools that you can use. Let me teach you how to use those diagnostic tools. So I think the coaching was a huge part of a lot of our successes.
I'll get your cupcake for you later.
One thing that I was thinking of is, beyond the standards which are well established and create a foundation, it's almost like it needs to be complemented by an ongoing implementation resource that evolves through some of these kinds of experience and so on. So I think even since we started this project, across Ontario today, there's a telephone coaching program called Bounce Back that's available to everybody right now. It could be written right into the standard, or at least examples out. There's a peer community created called Big White Wall, and these are both funded by the province of Ontario. And Bounce Back has the capacity to serve 43,000 people with telephone coaching this coming year. In Ottawa, there's been development of the Ottawa Depression Algorithm. All these tools are completely consistent with the guidelines, but people kind of have to figure out the connection between them two on their own, and we could be continually promoting those kind of connections.
Great. So it sort of went from the executive support, alignment with other priorities and things organizations are working on, right down to the facilitating easier and more consistent access to known tools, right, that are available, and figuring out a way maybe at HQO to make sure those links are made so people aren't recreating the wheel over and over again. So that is really helpful. The fan favorite, Joe back there, has been writing down these ideas on our sheets so we can take them back to the team and figure out how we incorporate this advice into changes we're making and where we're focusing on next year, and enhancements that we want to make to the program to make it easier. And we'll be keeping up with the alumni group, I guess we could call it, from this cohort, and keeping our eye on the upcoming cohort that's also going to tackle a quality standard, to see if we can't continue to refine how we're packaging this up to make it as easy as possible for people to implement out there across the healthcare system.
Just a quick comment. I think it will be useful to have the HQO send us some materials that you can post and put for patients to see and everyone to see on our hallways. I felt throughout the ideas program that I wanted to actually get the ideas logo in there, or get something that will just show up in color and just appeal to the folks that are passing by, and have them stand and look at it.
Yeah, something around the quality standard
It's
itself.
promoting it and just making it, it's here. We are an organization that is committed to these standards, and this is why, something that could help us, a visual.
Right, sort of like the choosing wisely type of posters type of thing to promote the idea. Yeah, that's a great idea. Okay, any last words? Oh, last words of advice maybe over here.
Just one thing, I think this is going to be many years before it's fully and truly implemented. And it almost seems like every year, each of the standards, we have an update, and that it provides relevant literature each year, sort of, so people are not going back wherever they join in. Like, we might be focusing on depression this year, but the anxiety standard might be a year later. Well, it'd be nice to build on what's already there versus starting from scratch. So somehow it's like a story, and if you can incorporate that into the standards of where it's at each year.
So that is a really good suggestion, especially given the staggered nature of those topics. Something else that we're looking at is whether we need to give more thought to clustering topics. So if the implementation would support advancing a number of things, does it make sense to have a 6 or 9 month gap between releasing certain topics, or does it make sense to do a few together? And we did that a little bit with these mental health related standards, but we always feel the tension between saying, is it a good idea to put a few out together, or is it overwhelming to put a few out together? And I think we maybe need to work with some teams who are out there in the field to crack the code of when is there actually an efficiency in bundling a few topics so that your implementation and improvement interventions could actually advance a number of things at the same time. Instead of saying, oh, we just did something and 9 months later, oh, here's another standard, and we could have sort of piggybacked on our earlier efforts. So that's something we should think about as well. Yeah. Okay, I think that brings us to time. So
excellent, Michelle. Thank you. Thank you for coming.
Thank you very much.
Thank you for coming in, and I'll switch microphones now. Thank you for being open to hearing the feedback, right? And so, and thank everyone here for being as open and honest to share your feedback about it. So, it's the end of your graduation day. So, inspiration. Did you inspire each other? Yeah? Yeah? Are you feeling motivated? Maybe after the weekend? Yeah, you are. You are. And I would encourage you on the celebration part, as much as today should be and is a great celebration, make sure you celebrate back with your own organizations as well. Share your certificates, share your photos. Get on the agendas of committees and organizations that you can talk about what you did and how quickly you did it and what your experience was like, because that's huge. So pat yourself on the back and let others do it as well. It's really important. Christian, I have a slide. I just need a date slide up here. Christian, can you put up a set of slides for me? Just want to, it's not about goodbye today, and I'm watching for a slide that says it's not about goodbye that will come up. This certainly is not the end. As I mentioned, this is just graduation. This is just a date on the calendar, and it is not, certainly not the end of your experience. And it's not goodbye from us. You'll get emails from the advisors Monday, maybe on the weekend, depends on how we feel. But there are a number of important things that are coming up for you. You now not only are an alumni's graduate, but you are part of the larger QI community. And as such, you will experience alumni webinars. First one is March the 22nd and then on change management. And then we have one in April, one in May on data and measurement. We also are offering for Cohort 12 and Cohort 13 combined, because you graduated a week apart, a sustainability webinar that will be on March the 29th. So we're asking you, and you'll get all this in an email if you haven't already, we're asking you to fill out the sustainability guide and come on the line with us, and we'll help, based on what you're seeing in your sustainability results, help you to think about, well, what are our next steps then? And hopefully you'll be able to share with each other, because I know some of you are already on that journey. Your alumni event is this fall, October 15th. I'm looking at my colleagues because I don't have my slides. October 15th? 16th, thank you. So your alumni event is called QIPSIF, the Quality Improvement and Patient Safety Forum, and it is free. There are about 800 some odd people that come, and it is the day before health quality transformation, which many of you know. And so it's a kind of a twofer. Oh, here we go. It's kind of a twofer. And so that you'll be able to not only be able to come and see your colleagues and to, oh, and I think he's guiding it from the back, thank you. And not only to see your colleagues again, but to see other colleagues who have graduated before you, lots of workshops and events. You will all be asked, and again, this information will come out on Monday. We need it by next Friday. I'm kidding. I was just seeing if you're paying attention. You will bring to QIPSIF a poster and an abstract, and we have some timelines for that and some templates for you to use. We will also be asking you to create a project summary, a little quicker than your poster and your abstract, that will be posted onto Quorum. And if you go, some of you have gone to Quorum and seen some of the projects that have gone before you. You also have not one, but two new groups to join. So one is the Alumni Community of Practice. So just like you got into Cohort 13, our private group, you're now going to go in and click groups, and you're going to be part of the Alumni Community of Practice. And that practice grows every day. You're part of our alumni database now, which is currently numbering about, Agnes, what are we, sorry? 2,500 people. You're now part of that network as well as you saw the breadth and depth of tools that had been developed through this cohort. So we will also have a community of practice around major depressive disorder. We might make it a little bit broader around that to address the more than one quality standard, where now you will be able to post those tools and resources still for each other, but for others who didn't have the advantage of being able to go through this cohort as well. So lots of activity, like it is that Hotel California you can check out, but you cannot say goodbye because there's lots of things that we'll be asking you to do. Keep meeting regularly. Last week we had a couple of our graduates who were able to talk to Cohort 12, and the one thing they said is, do not take your foot off the gas. This is not the time to say, let's just set a meeting date, you know, in the summer or in June. I'll send out a meeting invite in a few weeks. You won't do it, right? So I'm not saying you have to meet next week. And the week after that's March break, I get it, but it's not the time to take the foot off the gas. So do get those meetings in your calendars, do commit to it. Maybe it's every other week, maybe it's once a month, but these things don't take care of themselves yet, right? And you've got more work to do, right? You had those big driver diagrams, pull them back out and see what you can do from there. But do celebrate, do be really, you know, thankful and appreciative of each other and be happy about what you've been able to achieve in a very short period of time with things like holidays and staff turnover and all of those things involved as well. So thank you to our panelists, to Michael and Ross for being here today, and hope you enjoyed it as much as we enjoyed the interaction with you, and I'm sure Paul would say the same. Thanks to all our ideas staff, Claire, our rock solid person who makes all of this happen. Thank you. Have a safe journey home. We'll be in touch next week. And thank you for your energy and your engagement today. Really appreciate it. Good luck.